So we proceed with the first part, which is how to plan for a knee conservation, having decided that this patient would benefit from knee preservation. And the most important thing is that we have to have a full length X-ray, which is taken from hip to ankle and the patella facing front. And when we see this diagram, the patella is seen in the center. So this is the essential part of the preoperative planning. Then we draw the mechanical axis to find out whether it is normal or deviated. And for this, we mark the center of the hip. Then we mark the two convex points on the femoral condyle, join them to mark the distal femoral joint line. Then we draw two perpendiculars at the end of the condyle to this and mark the center of the condyle. Similarly, we mark the two concave points at the tibial plateau at the subchondral line, join them, draw two perpendicular line to it at the ends of the condyle, mark the center, and similarly, we mark the center of the ankle joint by dividing the distal femoral condyle, the distal tibial condyle by talus. And then we connect these two points, center of the hip to the center of the ankle. And if this line is passing medial, 15 millimeter medial to the center of the tibia, that means this patient has varus and it will require correction. But then we have to decide where the deformity is, and then we draw the femoral axis and the tibial axis and measure the mechanical lateral distal femur angle. And if it is up between 85 to 90, then it's normal, as shown in this case. But on the tibia side, the medial proximal tibial angle is 78. That means this is the cause of deformity, and we'll have to do a osteotomy at this. As we discussed, this can be done by two methods, either a medial open wedge or a lateral closed wedge. And to decide further, we mark the Fujisawa point, which is the place from where the weight-bearing line should pass in the patients who have nearly lost their cartilage. And usually this is the condition when patients approach us. We draw a line from the center of the hip to the Fujisawa point and extend it. This is the future weight-bearing line. And after that, we define the hinge joint. For an open wedge, this is just proximal to the tip of the fibula. And we draw this line from the hinge point to the center of the ankle. And then we rotate this line onto the futuristic joint line and measure the angle alpha. Now this angle is transferred onto the hinge joint, and this defines the amount of wedge which has to be opened, and h is the height of the wedge. This shows the BC is the opening, and this is the alpha angle. But when we have to do a closed wedge high tibial osteotomy, the way we'll be doing it today, we draw the line which is the futuristic joint line which we want after the osteotomy. Then we mark the hinge point which is on the medial side, because we are going to do a closed wedge osteotomy. And then we rotate a line from the joint line, from the hinge joint to the center of the ankle, and this is the alpha angle. This angle is transferred onto the lateral side, and once we take out this wedge, we close this and the alignment is corrected. Now this wedge could be removed above the tuberosity, like Dr. Maheshwari will tell us, or below the tuberosity, like we'll be having discussion on this from Dr. Thakkar. So now I request Dr. Maheshwari to give a talk on lateral closed bridge osteotomy, which is above the tuberosity.